Today's lecture on the series of Monty Hart. It's a great pleasure for me today to introduce Dr. David Vorchheimer. David is someone who I have known and learned to admire from the time when I was at Mount Sinai, now over 15 years ago. David is a graduate of Einstein, and after completing med school, he spent most of his career at Mount Sinai, where he established himself as a leader in clinical cardiology. He has fortunately returned back home, and we were very fortunate to get him to lead our clinical section here. He is going to talk to today about a very important topic, a topic that has become more and more relevant because of its prevalence and because the associations that it has with diseases that we treat here all the time, such as atrial fibrillation. So, David, pleasure to have you give this lecture today.
Thank you, Mario. It's certainly a pleasure to be here. I just want to correct one thing you might have said in the introduction. You said that the majority of my career was at Sinai. I hope that's not true. I hope I'm here for quite a long time and I can eclipse my years at Sinai. Having said that, thank you for the introduction. As many of you who do know me know, as Mario just said, I'm a clinical cardiologist. I'm not a sleep medicine specialist. I'm not a pulmonary person. I'm just a general cardiologist. But I think as Dr. Garcia just intimated, all of us have become increasingly interested in sleep apnea because of the pervasive overlap between sleep apnea and so many of the conditions that we all treat on a day-to-day basis. In terms of disclosures, none. I think it's sort of almost redundant at this point to highlight how sleep apnea sort of lies at the centerpiece for most of the cardiovascular conditions that we treat. And we're going to be focusing today, for the most part, on atrial fibrillation and hypertension, with a nod towards some of the other clinical conditions. I'm not really a basic scientist, as most of you know, so I don't really want to sort of go other than sort of the obligatory nod to the underlying pathophysiologist. I really just want to sort of focus on this part of the equation, where the destructive effect of sleep apnea really comes in, and where the management of sleep apnea can really influence the outcomes that we seek for our patients with sleep apnea. The prevalence of sleep apnea underlying or associated with many of the conditions that we treat is actually really staggering. And one of the points that I really want to sort of make today is how common it is in general and how common it is in our patients here in the Bronx. Because it's really, and I'll show you some data really from here towards the end. The range of the detection of sleep apnea depends a little bit upon how you define it and what testing modality you use, but suffice it to say that sleep apnea is really the low-hanging fruit of the bread and butter of the kind of patients that we see on a day-to-day basis in our inpatient clinics and in the hospital wards. One of the things, as Mario mentioned a moment ago, that's become fascinating about sleep apnea is that for a long time it was this kind of arrangement, which is the association and prevalence between underlying conditions and the cardiac manifestations, the cardiovascular disease. As we move sort of towards a different phase of medicine in general, one of the most fascinating aspects, and we'll touch on this a few times during the talk, I hope, is the idea that sleep apnea really can sort of foretell the future, and that sleep disordered breathing in general and sleep apnea in particular is really not so much only a problem for the cardiovascular condition that the patient may have now, but for the development of cardiovascular conditions in the future. This was a giant study from the UK Biobank looking at basically a questionnaire about sleep factors, whether you consider yourself a day or night person, how long you sleep, how well you sleep, that kind of stuff. And what you could see across the board in terms of prediction over years is that for the quintiles of scoring, the hazard ratio is actually pretty straightforward, that each incremental point that is achieved in this essentially made up scoring system, separate and apart from all the conventional risk factors for cardiovascular disease, and separate and apart from all the genetic markers that might be harbingers for cardiovascular disease, sleep disordered breathing on its own really functions as a very significant decisor of what was happening in the future. And this was even, as I said before, this trend held regardless of the genetic risk for the biomarkers for cardiovascular disease. So I think as we in clinical cardiology think about sleep disordered breathing in general and sleep apnea in particular, it's not only at the basis for what's going on with the patient today, but it really may be the cornerstone in a bad way for what may be happening with the patient tomorrow. Now, we tend to think of sleep apnea and a lot of the conditions that are presented here as diseases of the patients. There was a grand rounds here about a year and a half ago, maybe pre-COVID, looking at the factors that influence physician burnout. And there's abundant evidence now that if you look at the risk factors for sleep, for physician burnout, one of the most powerful determinants of physician burnout and physician wellness is the adequacy of physician sleep. Not necessarily sleep apnea per se, but sleep overall. And one of the sort of scary observations of the interaction between whether or not we tend to be tough guys and assume that we're never going to burn out, there's a fairly significant and fairly steep slope of medical errors that are associated with inadequate sleep. That's true at the trainee level, so we have to be mindful of that as the fellows, but it's true at the attending level as well. It may be that there is less prone to errors because they're less sleep deprived or perhaps have better experience, but that gradient is still here. And it's an important thing for us to realize in terms of our own wellness as we care for ourselves. So, one of the other things that's actually fascinating about sleep apnea in terms of, where it sits at the interface, a lot of this data is sort of intuitive and self-evident. What I'm going to really share with you today is what I, as a cardiologist in general clinical practice, have learned about sleep apnea over the years. The truth is, like many, I was aware of sleep apnea. I thought it was important, kind of, but I didn't really understand how important it was until kind of by accident. A number of years ago, probably about 10 years ago, a little bit more maybe, I was actually going to one of the sessions of the American Heart Association on the treatment of complex hypertension, on resistant hypertension. And I had a patient at Sinai who there was a dispute among a bunch of the endocrinologists about whether that particular patient had Conn syndrome, whether they had a hyperaldosteronism. And I emailed somebody who I thought was a thought leader, and I asked him a couple of questions, and it was right before the ACC, and he said, I'm speaking at the ACC. Are you going to be down there? Maybe we could sort of talk in person. And I said, sure. So he sent me the session that he was speaking at. And I went to that session, but as many of you who've gone to the ACC know, they often mess up the schedule, and the person who's supposed to speak at 11:20 ends up speaking at 10:50 because somebody else had to go to an investigator meeting or whatever it is. So I got there half an hour early, and lo and behold, the talk that was ongoing had to do with the interaction between sleep apnea and hypertension. And what I came away with from that study, from that speaker, and the truth is I already kind of have forgotten what the hyperaldosteronism aspect was, but what I came away from that presentation about sleep apnea was that if the patient has underlying sleep apnea and troublesome hypertension, you can never get rid of the hypertension until you treat the sleep apnea. And that sort of intrigued me at the time and sort of set me on, as a clinician, the idea that kind of filed away. So a lot of the observations in terms of the interaction between sleep apnea and incident diseases, as we talked about at this stage of the game, are kind of self-evident. So for example, here's one of many studies looking at the interaction between sleep and blood pressure in midlife. And again, looking at sleep disordered breathing in general and sleep apnea in particular as a predictor of what's happening in the future. Not as an association in terms of a snapshot, but what's going to be happening. This is the Cardia study, which is a large-scale observational study analogous to Framingham, conducted in the middle of the United States. And no surprise that that there is a likelihood of change in blood pressure, which correlates more or less linearly with the adequacy of sleep. What was fascinating in this study is that this study looked at discrepancies in race, in terms of the progression to hypertension between whites and African Americans. And what was fascinating was that, and this was published a long time ago, way before, the contemporary sort of view, that sleep duration accounted for the entire difference in the progression to hypertension that is associated with African American race. Now, why that is a different question, but it was just sort of an interesting observation in terms of how we understand the utility the role of investigating sleep disordered breathing in the management of our patients. So I want to kind of cut to the chase and go a little bit out of order and start from the macro and then sort of coalesce back to the beginning, to the micro. So it's no surprise that if sleep disordered breathing is such and obstructive sleep apnea is so relevant, then it would be kind of a chip shot. It would be kind of a layup to prove that the initiation of CPAP in patients with obstructive sleep apnea would prevent cardiovascular events as they are defined. And many of you saw this fairly important study in the New England Journal of Medicine, now about 5 years old, which distressingly showed that when you look at a composite of cardiovascular endpoints, CV causes MI stroke, death from any CV causes rather, MI stroke or hospitalization for heart failure, unstable angina or TIA as a composite, no difference between the patients who got CPAP versus usual care. And this really sort of, put a big sort of break on the enthusiasm, but it also called into question, obviously a mechanistic question, which we're going to discuss a little bit further as to why that is. So why did the SAVE trial fail? Okay. So I think the conventional answer, which we'll come back to again, is that treatment for obstructive sleep apnea with CPAP is not a yes or no kind of thing. It's not like taking atorvastatin for hyperlipidemia or an ACE inhibitor for heart failure. It really has to do with compliance in a very literal way. I don't know why that is, apologize for that. But the mean duration of CPAP adherence was probably below the threshold of what you need to make a difference. It was only about 3.3 hours per night. And that's probably less than half. And many people believe that there's a threshold, which is that if you're not at the threshold, it's as if you did zero. It's as if you did zero. Interestingly, the patients with the most severe obstructive apnea were excluded, particularly those who are hypoxic. It was actually interesting that they looked with a pre-specified endpoint back to the compliance issue at those who used CPAP for more than 4 hours. And in those patients, specifically the risk of a cerebrovascular accident was substantially lowered. So there was certainly a signal here that appropriate adherence does make a difference. There's another point which we'll talk about a little bit later when we talk about some of the other ways that sleep apnea can harm the patients in terms of the timing of CPAP. Namely, that there's a disparity in all of us between the intensity of sleep at various periods of time. And in many of the trial patients, the CPAP may not have been used during the most vulnerable time of sleep. And again, that seems very sort of elegant and sort of like really stretching it a little bit, but I'll show you some data a little bit further, which suggests that this may actually be part of the study. The other thing which I would point out is I looked at this study when it came out, and certainly as I moved from Manhattan to Montefiore, the thing that struck me most about the study, and it was a very large study, 2,800 patients or something like that, very well conducted, was one thing in the very vexing table 1, which is what did the patients in the trial look like? And the body mass index, the average in those patients was about 28. In the patients with CPAP and the patients without. And I would submit to you, for those of us who are here in the Bronx, that is not exactly the prototypical BMI of our patient with sleep apnea. And that, again, may have been just sort of a barometer of the severity of the sleep apnea, perhaps a barometer of the comorbid conditions, perhaps other things as well. But there's a number of reasons why that might be the case. Having said that, there have been a larger number of trials which have looked further to see whether CPAP in fact does prevent major cardiovascular events. And the data is really not that enthusiastic. You can see down here at the bottom of a very, very long list of trials, the point estimate is really right around 1. And even if you blow it up, it's still for a variety of individual endpoints, acute coronary syndrome, stroke, hospitalization for unstable angina, heart failure. Again, the point estimate is not very reassuring. And again, one way to look at that is to say, well, the hypothesis is wrong. CPAP is not that, sleep apnea is not that important, or CPAP is not that effective. But again, it's very vexing and it's in the details, as it always is. If you look at a more recent and more sophisticated analysis, which discriminated outcomes according to patient adherence, intention to treat analysis versus adherence. Once again, you find that in those trials where they looked at the difference and the significant discrepancy between those patients who were enrolled into the CPAP arm but were not really using it versus those who were enrolled in the CPAP arm and were using it as prescribed. Here you see in large-scale clinical trials, fairly significant reductions in favor of CPAP in terms of preventing the large major composite cardiovascular outcomes. But as I said before, what I'd like to sort of spend most of the time with, because I think that's really where the interesting stuff is, on the individual components of our patients in practice. So obviously some of the oldest and some of the strongest data for the interaction between sleep apnea and cardiovascular disease and the potential implications for therapy have to do with hypertension. And this was a meta-analysis a number of years ago looking at the impact of CPAP therapy on blood pressure. And again, it's all very reassuring, except if you look at the magnitude of the impact on the y-axis, and the magnitude of the y-axis varies between 1 and 2 millimeters per mercury overall. So very important in terms of statistical significance in ambulatory blood pressure. I think those of us who work up in MAP or Hutch would venture to say it's pretty hard for us to sort of find the patient in whom we've sort of accomplished a 2 millimeter reduction in blood pressure. At the same time, if you look at sort of larger things, and there's older data even looking at two-dimensional echo, that over time, CPAP compliance, when you're compliant and the blood pressure does go down, can reverse some of the underlying structural destruction that occurs in the heart as a consequence of untreated sleep apnea. And again, if you look at the meta-analysis overall, the conclusion is that it's associated with significant reductions in ambulatory blood pressure, but not really what we as clinicians would consider clinically meaningful. So I think, once again, there's a pause here to try to understand, why that might be. And I think there's a couple of sort of intuitive and a couple of sort of more nuanced, more elegant explanations as to why the antihypertensive effect that we can quantify in terms of day-to-day clinical operations seems much more limited than intuitively we would have expected. Part of it is that we know that hypertension is a very heterogeneous disease. And whereas there are many patients who have hypertension for various reasons, obstructive sleep apnea may be only one component. So CPAP may not decrease the blood pressure if the underlying cause of the hypertension is unrelated directly to in a causal way to obstructive sleep apnea. CPAP can only reverse certain intermediate mechanisms associated with obstructive sleep apnea. So for example, CPAP reduces sympathetic tone, which decreases blood pressure, but it may not reduce some of the other parameters like obesity or sodium intake or volume overload. And I think one of the key points, which is something that we need to keep in mind as we look at chronic conditions like hypertension, is that both obstructive sleep apnea and hypertension are chronic, indolent conditions. And if the sleep apnea-induced hypertension has really been longstanding, then it may be too late by the time we get to the patient. That remodeling of the vascular bed has already occurred, or baroreflex reset, and CPAP may not be able to demonstrate a reduction in blood pressure in the quote-unquote short term, namely in the conventional duration of the randomized trials of about a year. And I think this is actually quite plausible. I don't think that this is just sort of a made-up retrospect, beating up of the data to try to explain it. Because in a prospective analysis, looking at the impact of sleep apnea in an entirely different segment or silo of cardiovascular disease, namely the interaction with obstructive sleep apnea and acute coronary syndromes, 800 patients with acute coronary syndromes and screening for sleep apnea, those who had, we'll talk about in a second, moderate sleep apnea, about half of the patients have significant sleep apnea. So again, looking at the prevalence, another take-home point is that it's quite common. But if you look at the way the curves separate, for the first year entirely, there's really no difference between whether the patients have sleep apnea or not. And it's only after the first year, when you do the landmark analysis and restart it again, that you begin to see the very powerful and very hazardous effect of untreated sleep apnea on recurrence of events in patients with acute coronary syndromes. And I think this might actually be an important sort of take-home lesson, perhaps for future trials or perhaps for our own expectations in the clinic as we try to examine the impact of diagnosing and treating sleep apnea on our own patients. I think where the real money in hypertension is, in terms of sleep apnea, is in patients with resistant hypertension. And here again, some of the more interesting data that for every hour additional of CPAP use, there's a 2 millimeter or 1 or 2 millimeter reduction in blood pressure. And that actually is quite important, and that I think is quite, consistent with the theme that we've developed, that there are modest implications for blood pressure, but those implications can be sort of multiplied if the patient is actually truly adherent. And that's an important sort of take-home lesson for us in terms of encouraging our patients to be inclined and making sure that we have an appropriate partner in the sleep department for making sure that our patients are able to navigate the complexity of starting CPAP, because in the beginning it is an odyssey. And here again, if you look at some of the more random trials, some of the larger series of a composite, here you're already beginning to see much more significant reductions in blood pressure on the order of 10 millimeters in systolic, maybe 5 or 10 millimeters in diastolic, certainly in the meta-analysis as well. To move to a second condition that we take care of, which is congestive heart failure, CHF, again, across the spectrum of conditions related to heart failure, asymptomatic, symptomatic, even quote unquote diastolic, even acute heart failure, there's a gradient. Obviously, one of the things that is much more complicated about congestive heart failure is something that's been known about disordered breathing and congestive heart failure for a long time, namely that in addition to plain old obstructive sleep apnea, patients with heart failure also have central sleep apnea, which we have come to recognize as Cheyne-Stokes respiration, which is another different, but apparently also as well, a hazard for patients with sleep apnea. Again, in a large cohort of Medicare patients with newly diagnosed heart failure, so this was patients who were discharged from the hospital and had a sleep study at the time, looking at the interaction between treated sleep apnea on the top and not tested or not treated for sleep apnea on the bottom. And I think there's 2 points here. Again, the curves separate fairly quickly. Again, more than a year before the real benefit is seen. But most importantly, which is really kind of, I think, a snapshot of where we are as a cardiovascular community, 30,000 patients discharged from the hospital with sleep apnea, and 258 of them in a retrospective study diagnosed with sleep apnea and treated. So recognizing the slope for us in terms of what we need to do, in terms of trying to make sure that we can navigate this for ourselves. Okay, this is data from Carlos Rodriguez from the Echo Soul study, the ancillary group, the ancillary study looking at the echo images over time, particularly in minorities of Latinos in communities around the country. No association between sleep disordered breathing and left ventricular ejection fraction. However, there was a significant, a significant association between sleep disordered breathing and diastolic dysfunction, even in patients who had preserved left ventricular dysfunction, suggesting again that the real role for our intervention and diagnosis of sleep apnea may really be before it causes irreversible remodeling and essentially unfixable end organ damage. Again, one of the other sort of interesting things is the interaction as it plays out between sleep disordered breathing and clinical things that we just see all the time. So again, a quick look at an ICD, a bunch of ICD trials, which looked at the relationship between appropriate ICD therapy, in other words, the ICD firing for an appropriate ventricular arrhythmia, based upon the presence or absence of sleep disordered breathing. And lo and behold, not a surprise, in nearly 10 trials, the presence of sleep disordered breathing is associated with a substantial increase in the likelihood that the patient's AICD will firing appropriately. Now, again, we see these kind of patients admitted all the time, a patient who has an ICD in for prevention and the ICD fires, and we try to understand what may have happened clinically, electrolyte abnormality, change, ischemic event, whatever it is. One more thing to sort of think about in terms of trying to understand what we can do to prevent these kind of things from happening. Some early data that's emerging now about the relationship, again, between sleep disordered breathing in general and obstructive sleep apnea in particular, and atherosclerosis. Again, limited data in terms of the clinical syndromes that we see, myocardial infarction, acute coronary syndromes, but fairly interesting and fairly provocative data looking at non-coronary plaque burden, in other words, looking at carotid or aortic disease related to sleep duration. And again, the shorter the sleep duration, the more likely there was to be um, presence of subclinical cardiovascular disease. And the mechanism of that, again, has been documented recurrently over time, that among the many sort of neurohormonal changes that can be induced by the inflammatory state of sleep apnea, CPAP changes when it's administered can improve flow-mediated dilatation and arterial circulation. Now, in the first slide that I showed about cardiovascular conditions, I mentioned one of the underlying conditions was stroke. Now, we in cardiology interact with cryptogenic stroke a lot. We do a lot of TEEs for the diagnosis of cryptogenic stroke. And obviously a major thrust of our secondary prevention after a first stroke, in collaboration with our neurology colleagues, is the detection of undiagnosed atrial fibrillation, telemetry monitoring in the hospital, loop recorders, the link, and so on and so forth. There's a fair amount of evidence, and this really became highlighted a number of years ago with the death of a Supreme Court justice and the speculation that untreated sleep apnea contributed to the death of Justice Scalia. And the reason was exactly that. He was apparently a very meticulous man, and he was on vacation or at a convention in a hotel away from his room. And when he didn't respond to phone calls, the hotel security broke into his room. Everything was perfectly tidy. He had apparently fallen asleep on his bed, and next to his bed on the night table was his CPAP machine not plugged in. And that raised, obviously, a lot of sort of interest in the interaction between stroke and undetected sleep apnea. And it's quite powerful, as I showed you in the first slide. The reason why that might be, again, why would there be a relationship between stroke is part of a narrative about sudden cardiac death and sleep apnea, which is that patients with obstructive sleep apnea have a peak in sudden cardiac death during the sleeping hours, which is very different from the general population or people without obstructive sleep apnea. Looking at the peak in terms of the time of day, in terms of when patients with obstructive sleep apnea die versus when patients without sleep apnea typically die. And the suggestion obviously is that during the night, during the hypoxia, arrhythmia, other changes can affect and sort of concentrate the likelihood of sudden cardiac death at night. The last thing I really sort of wanted to talk about in terms of individual disease states was atrial fibrillation, because here is probably where the greatest body of evidence is, and where also the greatest connection, the strongest connection between the underlying pathophysiology and clinical outcomes. This is data from the Brigham. Luigi DiBiase was a main author of this whole bunch of series of investigations when he was up at the Brigham before he came down here, looking at essentially the anatomy, the triggers, the substrate that allows for the potentiation of atrial fibrillation, and the distinction in patients who have atrial fibrillation undergoing ablation with sleep apnea and those without sleep apnea, and the prevalence of pulmonary vein triggers and how frequently they are, even in patients after pulmonary vein ablation. Okay. And again, the takeaway point being that the pulmonary veins we know are the main triggers for atrial fibrillation in patients with OSA, but extrapulmonary vein triggers are highly common in this population. And obviously, if the arrhythmia folks don't go after them, and if sleep apnea is not really treated, the atrial fibrillation comes back. Now, the examination of sleep apnea in patients with atrial fibrillation has obviously taught us a great deal about the mechanism of atrial fibrillation, but it's also taught us a lot about sleep apnea in general and how our ability to detect it. So one of the things that's actually interesting is that whereas we typically rely on an overnight sleep study or somnography, and I'll show you the home sleep studies in a second, is that there's a considerable night-to-night variability in sleep disturbed breathing, which can often be missed by a single overnight sleep study. So this was 3 representative patient profiles in an Afib trial looking at sleep breathing. So patient 1 has overall fairly low sleep disordered breathing. In orange is the most significant sleep disordered breathing by number of events. In green is the least severe. And what you see again is that using another index for measuring sleep disordered breathing, the RDI, the respiratory disturbance index, which can be monitored directly from the pacemaker, which enabled the investigators to monitor the sleep distorted breathing over many, many, many days, over a course of a month here or even longer. what you see is that you would get a completely different picture depending upon which day you measured. So for example, if the patient wore their sleep monitor here, they would come out as being normal and not having any sleep apnea. Whereas if you measured them over here, you'd get an equally incorrect and imprecise view because you conclude from here, probably erroneously, that they have significant sleep apnea. At the other end is this patient with, prototypical patient with severe sleep apnea. Most of his or her recordings are in the orange or green, the most severe sleep disordered breathing. Again, if you sampled this patient on this night or this night, you would have an understanding that this patient's at fairly significant risk. But if you measured the patient down here, you could incorrectly conclude that this patient didn't have sleep apnea. And again, what I've taken away from this, personally, is that there's a patient in whom I'm highly suspicious that they might have sleep apnea. Every once in a while, I might do it again. Just repeat the test if the first test is negative, because I'm always wondering if the negative test that I got is this guy sort of being here in the green bar, when reality, looking at the total spectrum. And there are many people who are now advancing the notion that you have, just in the same way that we do more extended Holters to detect for atrial fibrillation and other arrhythmias, that perhaps the detection of sleep disordered breathing, as it will come with sleep apnea with better technology, might be better done over more than one day. A second very, very important outcome of this trial in terms of our understanding has been something that's been, a chicken and the egg kind of question that's been there from the beginning about the relationship between sleep disordered breathing and atrial fibrillation, which is everybody gets it that sleep disordered breathing can cause atrial fibrillation. But many people have long speculated that atrial fibrillation actually can then result in sleep disordered breathing. And because these doctors actually had the pacemaker device to measure both the sleep disordered breathing with the RDI as well as the Afib, they were able to resolve this age-old sort of chicken-egg controversy, I think, effectively, definitively. And the conclusion is yes, that sleep disordered breathing begets atrial fibrillation. This is the odds ratio for the development of atrial fibrillation according to the quartile of severity of sleep disordered breathing. And you see the gradient is there for 5 minutes of AF, for an hour of AF, for 12 hours of AF. The worse the sleep disordered breathing, the more likely it was the patient to have atrial fibrillation. But the other way around never really panned out, which is that even though the patient may have had shorter durations, middle durations, longer durations of AF, it had nothing to do with the causality in terms of the severity of the sleep apnea. Now, the main sort of interest for atrial fibrillation in terms of sleep apnea has been pretty solid evidence thus far for a number of years now that effective obstructive sleep apnea treatment can really deter and prevent atrial fibrillation recurrence. This is a meta-analysis that came from NYU a number of years ago. And again, what was fascinating here, it confirmed something that I think many of us had speculated for a long time, which is that if the patient has uncontrolled uncontrolled sleep apnea, you can do whatever you want to the atrial fibrillation. It's never going to go away. And a whole bunch of trials, nearly 7 trials in this study, quite a number of patients in recent years, with pretty significant reduction, about a 40% reduction in recurrence of atrial fibrillation. And it didn't matter how the atrial fibrillation was treated initially. In other words, this was true for patients who were treated with cardioversion. This was true for patients who were treated with atrial fibrillation ablation. The treatment of sleep apnea prevented. So for those of us who take care of our patients after sending the patients to AFib ablation, thinking about diagnosing and treating OSA ablation, obstructive sleep apnea, is a very thoughtful and I think very evidence-based way of preventing recurrence of atrial fibrillation after the index procedure or intervention to restore sinus rhythm for atrial fibrillation. So, one of the things that I think we've grown accustomed to is we all think that we can identify patients with sleep apnea. We think of the prototypical patient, we think of the prototypical patient risk score, and we think of the patient specifically prototypical body habitus to help guide us either in asking the patient whether they might be at risk for sleep apnea or proceeding to study the patients with sleep apnea. And this was a study, you'll recognize 2 of the authors down here, the only 2 authors on the paper, Lynn Zaremski before she was a fellow here, and Ron Wharton while he was still here, looking at the outcomes in patients mostly at the Hutch as the widespread screening of sleep apnea in a general cardiology practice. And what they found, which was kind of interesting, was that BMI didn't really predict AHI. We'll come back to that in a little bit later because I think there's a little bit of a disparity between some of the other trials, and I'll show you some other data from here in a moment. But it is becoming increasingly sort of reproducible in a large-scale set of clinical trials that the way we thought we could identify patients clinically with sleep apnea, particularly in cardiac patients who already have the consequences of sleep apnea, like high blood pressure, like heart failure, like atrial fibrillation, we're not really that good at predicting who's going to have sleep apnea and who's not. This is a more nuanced way of trying to predict the presence of sleep apnea using one of the scoring systems, the Epworth sleepiness scale. Again, the scattergram is all over the place. This is another observation using the stop bang, which is the rival questionnaire, the one that we typically use here. And again, the takeaway point is that it's more or less a coin toss in terms of where it comes out. Sleep questionnaires are not predictive in patients with atrial fibrillation. And in fact, there was just a paper a couple of weeks ago in JACC EP of 180 patients referred for ablation without confirmed OSA, where they basically didn't really bother to screen them. They just tested everybody. And that's supposed to be an 82%, I apologize, typo. 82% of the patients referred for ablation had a positive sleep study. And of those 82%, more than half had moderate severe sleep apnea. So the question is, why are sleep apnea symptoms less predictive in AFib patients? It makes so much sense that the questionnaires that we should have should be so reliable. Why don't they work? And there's a bunch of different reasons that are speculated. And again, some of them are quite elegant and some of them sort of cause us to pause and think a little bit about what we assume to be correct in our patients with atrial fibrillation. First and foremost, a lot of the questions on the questionnaires targeting symptoms attributed presumptively to obstructive sleep apnea are already quite prevalent in patients with atrial fibrillation due to the impact of the atrial fibrillation itself on the symptoms and quality of life. We know, for example, that AFib results in a significant increase in sympathetic nerve activity. This has been documented for a very long time using electrograms. And the takeaway point again here is that a lot of the symptoms that patients might feel in terms of disturbed sleep, inability, insomnia, arousal, all those kind of things may in fact be related to the atrial fibrillation and have nothing to do with sleep apnea. In patients with atrial fibrillation, asking themselves, how do you feel? Again, it's a total scattergram across the board. No sleep disordered breathing, mild disordered breathing, moderate, severe. There is no way that this can come in any sort of significant, useful way to help predict sleep apnea of any severity in patients with atrial fibrillation. Essentially, as we said a moment ago, it's a coin toss. Okay. So patients with atrial fibrillation may not experience excessive daytime sleepiness in the same way the general population does. And excessive baseline sympathetic nerve drive, as we said, may counteract the sleepiness, so patients are actually stimulated and are awake. What is interesting though, and this is I think where we come in here in the Bronx and in the larger clinical cardiology, is that there's been several observations now that suggest that in fact, what predicts obstructive sleep apnea among AFib patients are clinical variables, not necessarily the patient's symptoms. And the two that have emerged most reproducibly, a little bit in contradiction to the general cardiology practice, are age and BMI, and particularly BMI, which is associated with a fairly significant increase in the likelihood of detecting sleep apnea. So clinical variables do predict sleep disordered breathing. Here's another trial, again, in looking at male gender, diabetes, and again, obesity, BMI, and a history of a stroke. So I think the takeaway point, and I've sort of looked at this and adjusted a little bit what I do, and I'll show you that data in a second, that maybe we can just sort of look at the patient, and it actually helps us because we don't have to administer questionnaires. We'll talk about that in a second. But basically, when the patient has the underlying condition that we think might be benefited or the condition might be ameliorated by initiation of CPAP, it may be worth testing them. So as many of you know from private conversations that we've had, we've been trying for a number of years to try to sort of develop a systematic way of testing for sleep apnea in the outpatient practices here within Montefiore. And we've gone through a bunch of different iterations. It's a complicated problem because our patients in general are not that enthusiastic. Their insurance is not always that robust. And diagnosing patients with sleep apnea is not like sending them for a lab test. It's a bunch of conversations in terms of why it's important. It's a conversation with a sleep specialist, and it's getting the sleep therapy provided. So since September, I have been working with a different system outside of the institution. And since September, in just my own clinical practice up here, I've sent now about 170 patients from MAP for home sleep testing. And the home sleep testing involves this relatively simple device. It's very different from the sleep apnea detection that's done in the sleep apnea lab, but it's FDA approved and it's equally effective for the diagnosis of obstructive sleep apnea. It's a fairly simple device. It's a bracelet that goes around the patient's wrist. It's a clip that goes on their finger and a piece of tape that goes on their chest. Nothing in their nose, nothing on their mouth, no mask, no nothing. And most importantly, particularly in the era of COVID, this test can be delivered to the patient's home and retrieved from there. So we've done some data analysis on the patients that have been referred through the beginning of 2021, largely because, as I said before, if you want to understand the disposition of the testing, it's not only about whether or not the patient was tested, that's the easy part. The real question is whether or not the patient ended up being treated and whether you've made a difference as a clinician. So again, this is kind of a representative sort of cohort, age range between 25 and 80. About 2/3 of the patients were female, and the BMI here was kind of, I think, much more representative of the kind of BMI that we're typically seeing at MAP and Hutch. And the truth is, on the basis of those trials that I showed you a moment ago, this was really the thing that sort of I tried to use without asking a lot of questions to the patients, because like you, I don't have a great deal of time to sort of go through questionnaires, but just sort of screening the patients based upon presence of a coexisting cardiac condition and a BMI that was above 30, just to see what happened in terms of our ability to detect. And lo and behold, of those initial 100 patients that were referred, we ended up able to do tests, connect 95 of them, which already is quite impressive. Of the 95, about 80 ended up going to get the sleep apnea study, which is actually quite impressive in terms of compliance here at Montefiore. And again, looking at the gradations of what we found, AHI, less than 5 is considered no sleep apnea. AHI, an apnea hypoxia index of 5 to 15 is mild sleep apnea, moderate sleep apnea, severe sleep apnea is an AHI above 30. Not surprisingly, because I was using patients in a cardiology clinic, actually there was 0 patients who had no sleep apnea. Equally not surprisingly, even among the patients who had relatively mild, only a smattering of the patients had what is the most liberal definition of not really having sleep apnea, which is an AHI under 7. And equally not surprising is that roughly 75% of the patients that were sent for home sleep testing actually had moderate or severe sleep apnea. And that, I think, is a very sort of important awareness for us in terms of how common this is. We have the data. So one of the things, just in terms of the logistics about how this worked, was essentially I faxed over a single 1-page questionnaire, which had only the patient's demographics on it. I didn't really ask the patients any of the stop bank questions or anything like that. The vendor that we have engaged was able to do that. So we send over the fax, they contact the patient, they deal with the insurance, they administer the questionnaire, which we'll have the data for shortly, and then they deliver the sleep device to the patient's house. And with that kind of sort of robust support, we were able to get in the Montefiore system, an overwhelming majority of the patients actually tested. And when the sleep apnea was actually detected, we were actually able to get a large number of the patients on therapy and compliant. Now, again, this looks like a relatively low number because it's 1/3 of the patients of the total cohort, but keep in mind that the 22 patients who are actually on it are coming from the patients with moderate to severe. So we're having just under 50% of the patients getting on therapy and maintaining therapy, which is actually consistent with the number that most of the clinical trials show, where on average, getting patients to be adherent to sleep apnea therapy is about a 43% enterprise. So again, this has been very important for us. We've been, I think, tinkering with a lot of the mechanisms in terms of what's going on. One of the questions that was a very important challenge as we embraced trying to sort of obtain assistance in terms of the Bronx population and the Montefiore population in general was whether or not it would be worth it, quote unquote, for them to do it. And I think, among the 90 or so patients that they screened, the insurance payer mix was sort of representative of what we see. The vast majority having Medicaid of a variety of different ways, Medicare, and a whole smattering of, individual one or two United Healthcare, which is now not dealt with. But the most important thing for me as a general cardiologist is two things. There have been a couple of patients for whom the insurance doesn't cover any home sleep testing. And there have been a couple of insurance companies where Montefiore is out of network. But overall, for me, which is, again, it's not always about us, but for me, I've sent 150 patients for sleep study at home, and I have not done a single pre-authorization. I have not had to do one. So we're hoping to roll this out in a more significant way, initially at MAP, at Hutch, to the arrhythmia clinic, and then throughout in an incremental way, because as you might imagine, getting this done is a fairly labor-intensive job. Thankfully, not for us, but for the service that we've been working with. It's not a surprise then, based upon this kind of evidence, that screening for atrial fibrillation, for obstructive sleep apnea, does appear in the guidelines. Sort of modest nod, I would say, not a ringing endorsement to in the ACC/AHA guidelines. Similar kind of like enthusiastic encouragement in the AHA, but not the most up and down cheering. But I think this may change, and I think for us here at Montefiore, where we struggle to bring a lot of disparate risk factors to our patients under control, I think we're poised at the point where we can actually implement something now that for all of you who are listening in terms of general clinical cardiology and specialty cardiology, we can make a difference hopefully soon. So I'll stop now. I'm not sure if Dr. Garcia, I know you have to step away for something. And we'll take some time for questions if there are any. I'll try to, if you could send your questions. Hi, Mario. And we'll take it from there. So thank you.
Thank you. Thank you, David. That was a very comprehensive presentation. I have a couple of questions maybe to start the Q&A session. So certainly a little disappointing to find out that there are no more, I guess, noticeable improvement in outcomes with treatment of sleep apnea when it comes to major cardiovascular events. But I wonder if you care to comment about maybe other endpoints that are, I think, also important in our population, for example, diabetes control and weight loss. And the second question I had, following that is, I wanted your opinion about the use of bariatric surgery for treatment of the OSA patients that have, more severe increased body mass index.
Yeah, so those are obviously two of the great questions. It's interesting. If you ask that same question to the bariatric surgeons, on the one hand, they would be simultaneously enthusiastic that they could do bariatric surgery to make OSA go away. But if they thought about it the converse way, which is that perhaps if patients lost weight, they wouldn't need bariatric surgery, they would actually be horrified. So the truth is that one of the fascinating things, which I didn't discuss today, but one of the things that's actually been most intriguing to me, as I've learned about this stuff, is the, again, chicken-egg dynamic in the relationship between weight and obstructive sleep apnea. So the reality is that, the relationship between weight and sleep disordered breathing has been known since the time of Charles Dickens, right? Charles Dickens' first novel had the character Pickwick, and that was his first published work. So it's that long that the relationship between weight and snoring and sleep disordered breathing has been identified. But what's been fascinating is actually the other way around, namely how sleep disordered breathing actually causes weight gain. So sleep disordered breathing of any sort, including sleep apnea, actually causes weight gain. And there's a lot of fascinating hormonal evidence to demonstrate what sleep disordered breathing can do to the hormones that regulate appetite and the hormones that regulate satiety and the hormones that regulate how, for example, triglycerides are stored and a bunch of other things. So yes, there is preliminary data showing that bariatric surgery in general, but weight loss in particular, can reduce sleep apnea. There's also interesting data that sleep disordered breathing causes weight gain, and if you fix sleep disordered breathing of whatever cause, sleep disordered breathing due to sleep apnea, sleep disordered breathing due to working at nights, sleep disordered breathing due to staying up at night and video games. All of those things, if you fix that, can actually result in weight loss. In terms of surrogate or preliminary endpoint, I think that's exactly the point. That while the global endpoint of cardiovascular events may not be attainable with sleep apnea, probably because by the time we intervene, the damage is too far done, there's abundant evidence on the incremental steps that lead to that outcome that can certainly, I think, have already been shown. There's evidence for glucose metabolism. There's already evidence for hemoglobin A1C. There's evidence for left ventricular hypertrophy, which I showed you. And hopefully, I've been speaking to Carlos about looking at some other parameters as well in a follow-up of the ECHO-SOL study.
Thank you, David. One maybe additional question. What I'm hoping that the rest of the fellows and residents are listening to this conference think about other questions to ask. I wanted to get your opinion about perhaps the very upcoming possibility that people will be able to self-diagnose this at home with the availability of devices that right now are becoming more sophisticated. Now, the Apple Watch that can give you O2 sats. I can imagine that it won't be too long before we can do an OSA study in everybody who has one of these watches at home.
Yeah, so it's actually important to keep in mind, which is something that I didn't realize along the way. So, the availability of an Apple Watch with an O2 sat meter is certainly something that's, noteworthy. Obviously, the older generation of O2 sat meter, if you were asleep, you wouldn't notice what was going on, but something like an Apple Watch potentially could. But the point of it is that what most of the devices that measure obstructive sleep apnea are not actually measuring exclusively hypoxia, because hypoxia is only one component of sleep apnea. So we think of sleep apnea as, the oxygen sat dwindling down to 80, which would certainly trigger on those watches. What these devices do, in particular this one, which is related to, which is similar to the EndoPat device, they actually can measure apnea, which is something that for the moment, I actually, I have a meeting in a couple of weeks with a company that has a potentially, consumer sale device that can look at a lot of different cardiovascular things, including potentially this. But I think that may still be a little bit down the road. Okay, so.
Well, thank you again, David. This was phenomenal. I think it's under-recognized, under-treated. We're always in a hurry. And, this is not one of the things that we think the most when we evaluate patients in our outpatient practice. But this is something that we need to pay more attention for sure.
Well, thanks very much, everybody. Have a good afternoon, and see you soon. And we hope to roll this out in a way that's very user-friendly for everybody, so that really all you have to do is send over a piece of paper with the patient's information.